Andy asked if I would just do something a little bit provocative, a little bit philosophical maybe, and quite honestly, I need to be sitting in a chair, my feet up, and a telephone in my ear to really be able to pull this off. This isn't my favorite venue to do this because I spend a lot of time on the phone, a lot of time in a windowless office. So it might explain a few of my quirks. But at any rate, what we're going to try to do today is just kind of go through a few things that I see as a diagnostician going on, and a diagnostician of a few years. I was a real vet, 35 years ago, and have been confined to this office for the last 25. So, but we're going to look at a few things as it relates to pig production, and maybe question a few things and give a few attaboys. I think some of the things I'm going to talk about probably are going to be talking to the wrong audience. We get to see the dirty laundry of a lot of different production systems. So, but at any rate, I have this hanging in my office, and as a kid, no TV, read a lot, Sir Arthur Conan Doyle and Sherlock Holmes stories, and having reread those recently, I was looking at this quote. Dr. Watson, of course, is the emotional one, the guy that very creative and can draw some conclusions fairly quickly from very limited information. And so this note is indeed a mystery. What do you imagine that it means? And as a diagnostician, I have to think a little more like Sherlock. I have no data yet. It's a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. And I think that's a really strongly insightful exchange, because that word insensibly, really talks about bias that we all have and we don't know, right? Insensibly, we begin to twist facts. So, if anything, I try to be a sounding board. Are we thinking right? And of course, I have my own bias. I'm a diagnostician. I get to see what's wrong. I get to access some information. I don't have to make decisions that influence the business viability. So I'm lucky that way, right? I can be smart because I'm 25 miles from home and don't have to really take any of the consequences of a decision. So at any rate, with that, we're going to ask a few questions. What do we know with certainty? And you look at what, where, when, how, why. Those types of questions are really basic. I don't think we can ask them too often. What, where, and when are diseases occurring? Epidemiology question. We have the tools. We have the PCR. We have the serology. We have good techniques. We have science. We have statistics. Works great. The whys. Folks like Dr. Hurley and many others are looking at the whys of this happening, the ologies. I think that's very interesting. Impact, so what? We have people out there that are trying to assess that, sometimes successfully, sometimes not. But then we have the interventions, the assessment, outcome, credit or blame. Those things get to be a little more opinion because they're harder to monitor. Quick walk through history. Back in the 1800s, early 1900s, germ theory, Pasteur did his deal. Salmonella was isolated. I think it's interesting. I put mycoplasma on here. I think it's kind of interesting. U.S. veterinarians eradicated pleural pneumonia prior to 1900, before they even knew what the cause was. And we are so saturated with information. It's kind of like one more bit of information is going to allow us to be successful. Maybe we need to back up a little bit and go, what's the biology telling us, about some of the problems we face. So I won't spend a lot of time on these things, but I was there with the lye-soaked oats and that sort of stuff. In terms of nostrums, and we have more diseases being discovered all the time. They have to fulfill Koch's postulates or they can't be real. I think we've sort of, come away from that just a little bit. We learned about vaccination in the 50s, 40s, 50s, 60s, controlled exposure, improved nutrition. As we put more pigs together in smaller places, we had to figure out nutrition. We had to figure out housing and that sort of thing. Along came antibiotics as crutches so that we would be able to do that more efficiently. Put more pigs in a smaller space all the time. Integration, contracts, genetics, those things drove a lot of innovation and contributed a lot to the expression of new diseases, I think. They weren't really new organisms, but they were new as diseases. Biosecurity principles, started learning a little bit about that. Isoine, age segregation, those things became very important. Then we enter this century in sequencing, metagenomics, all these words that are hard to pronounce. We have data, lots of data. And really, my take home from a lot of that data is biology's pretty clever. There's a lot of biodiversity out there. And we just have new ways of measuring it, but I don't know that it necessarily we understand it. And so I think we really need clinical and pathological context as we start pondering some of these questions. Just a window into my past, and there's one other guy in here I think that's older than me. But a lot of good pigs were raised very successfully with decent husbandry on the upper left. And then, there's straw, and there's, a little place for them to get hovers and all that sort of stuff. And then we start taking them outside. That picture on the lower right has a picture of it's a silo. You can just barely see the cement stave silo, when cattle feeding left Iowa. When that happened, well, let's contract some pigs and feed those commingled feeder pigs from, you name the state. And this Salmonella cholera suis is what I got to treat with LS50 day after day after day. No PRRS, right? We just had that problem. And so, technology is our friend. Things have gotten better, and I'm not trying to sound too negative here as I go through this, but technology does have a lot to offer if we're selective in how to use it and we don't abuse it by ignoring the other needs of the pig. So within these megatrends and solutions, what are some of the overriding principles of disease control? Natural immunity, controlled exposure isn't quite the same as natural immunity, herd immunity, if you will. But controlled exposure does have its pitfalls. That would be feedback and that sort of thing, purposely infecting animals that are previously naive or maybe not. But we know that there can be some negative outcomes to that, but there's also some positive ones, and I think those have to get weighed. Vaccines, lots of them out there that can work. When I was in practice, we could, if we could grow the bug, we could put it in a bottle and make a vaccine out of it, and we frequently did. That was how we were schooled. That's what we believed in. We thought we were doing a service to the producers. I think we, as we back up, we tend to generalize a lot, and so when we start talking about vaccines, we got to be thinking about the pathophysiology of each agent. What worked for pseudorabies didn't work for circovirus. What works for circovirus doesn't work for PRRS. And you kind of go in these circles of making these comparisons, thinking it's going to be, the answer is going to be like the last bug we had. And it's not, right? It's not. And so I think we as scientists, veterinarians, got to stay away from that generalization. Make sure we understand the complexity in the science as good as we know it before we go out and apply some sort of a nostrum or some sort of a intervention to a system. Eradication, high health, I think that's fantastic, and I think we have the tools that we actually could keep bugs out forever. Maybe not in Iowa, but I can tell you if one bug slips in, one pig slips through a system like that, we will have some problems. Antibiotics and nostrums, I think ultimately we abuse them to the point where long-term sustainability. I'm going to be talking sustainability. We talk about next quarter, next year. We got that all figured out. We're very cognizant of that. What about next 5 years? What about next generation? What about your kids, your grandkids? What's the sustainability of practices that we're doing for them? So anyway, comment on big data. Does bigger data lead to bigger decisions? In my job, I'm becoming a clerk of data manipulation, right? I just move stuff around, make requests, send out data. And I'm going, sometimes it makes sense, but sometimes I think, geez, are we spending the money the best way we should? Well, I think maybe big data is great as long as we're making better decisions. But I think, getting into the weeds can be a problem. If we're not using that new large data set to actually make better decisions and connect dots in a more systematic way, I think we certainly run the risk of drowning in it. And I'll have more to say about that in a minute. So metagenomics, metabolomics, I am baffled omics. It reminds me of Buzz Lightyear, right? to infinity and beyond. He's empty-headed, but he's excited and enthusiastic about it. It's biology. We're going to find differences. What do they mean? What's the what? Cause? Just talking about causation a little bit. Our human nature is going to want to find one thing, blame one thing. Find preferably what we were looking for, what we thought it was all the time. So our hindsight bias is going to be confirmed by our confirmation bias, and we're going to use selection bias to make sure that happens. We do that all the time. And do we assign cause, in the right spot? And so we've got necessary and sufficient causes, usually a virus. Something like PED, damn sure will make pigs sick. Necessary, not sufficient, that would be most of the rest of the stuff that we deal with. Another example of association causation, as we think about this, this is food sales of organic food on the left going up, years going across on the right, individuals diagnosed with autism scales on the right, right? That correlate, I don't know much about statistics, but P0001, Dr. Zimmerman, sounds to me like that might be the real deal. And of course we know it isn't, right? Association versus causation. But what happens when bureaucrats, politicians, and people that don't understand the difference get a hold of that? You end up with emotion-driven decisions. And I've got associates from Brazil, and he's going, because they didn't find Zika virus in a few of the newborn babies, truly a tragedy, with microencephaly, right, with Zika virus, because they didn't find it by PCR, therefore it couldn't have caused this condition. Those people don't understand biology, pathogenesis, pathophysiology, do they? But the bureaucrats are saying, we have association with glyphosate use. And so this Roundup is what's causing this. Dangerous when people making decisions are basing it on inadequate information. So what we're dealing with, the old triangle there, the host, environment, pathogen. And I don't know, we diagnose that stuff on that list all the time, right? And my sense is the practitioners out there grab that and run with it frequently, not all the time. But they're potential pathogens. They've been around for an awful long time. They don't have to cause disease. Have we stopped to go, is our system somehow contributing to that? And again, back to causation. There's a guy by the name of Jared Diamond wrote a book called Collision. It's a little bit of an environmentalist thing in a way, but it's also very insightful on, true causes. Causes of what happened today and now are usually what we blame, what we point to. But you back up a step and go, well, what was the step before that and the step before that? We start talking about that with root cause analysis, don't we? What really is the ultimate cause of some of the things that we're dealing with? And I think, there's ways that we can control our move to confinement, large populations, and pig density, and reliance on vaccines in a way that maybe has, some systematic approach to disease control for the long term, rather than thinking about what's the vaccine program for the next quarter. Charts. So far I haven't said anything that probably anybody cares about. Sometimes people get like tables, and so if you look at tissue cases that we get at Iowa State with respiratory disease over the last 5 years, and you probably could take that to 10, really about the only thing that's changing on here in terms of frequency or trend over the years is influenza. Influenza took a push up there in 2010, 11, 12, and has been trending upward. I'm not sure why. I probably could speculate on that. But most of the rest of these bugs that we've been dealing with are staying fairly flat in terms of trends. So we don't really have a hot disease per se going on that affects the respiratory tract or the systemic disease of pigs. Cumulative effects. When we're doing diagnostics out there, I think it's occasionally, I think we forget that it sucks to be at the bottom end of the distribution of a population, because you tend to get all the bugs and they accumulate, and at some point we're going to take that pig and try to do some diagnosis on him, and we don't know his history, that He was weaned, had rotavirus, had E. coli, and then a little bit of strep and a bad joint, and now he's out in the grow finish, and lo and behold, he has a few lesions of circovirus, or he gets mycoplasma or bacterial pneumonia. And so just to illustrate, thinking four-dimensionally, right? Four-dimensionally, that you got, time, you got organisms influencing individuals within distributions over time. And so if you look at what's affecting 3-week-old pigs, percentage of pigs that have these different things, or the percent contribution of these things to ill health, and you just kind of go down the line and things change. And of course, I made this all up, right? I mean, and because it's going to vary. I don't think it's wrong for one herd, but I know it's not true for all herds out there, right? So you go down the line, and you just get this concept that endemic diseases, and relative impact are where we're really stymied. It's not a matter if they're going to get exposed to the things; it's when and what will be the impact, and how do we frame up diagnostics to take advantage of the changes over time and be able to put context around the agents that we do find. I think it comes in the form of a protocol. This is again one of my favorite kind of slides. If you got some attribute of a population on the left-hand axis, and you got this population moving through time, with the dark line being the average of the population, and the red line being something bad has happened, right? On average, the pigs are doing fine. But it really sucks to be in the lower part of that distribution. Those individuals are not doing fine. Epidemiology probably isn't going to identify those. It's going to require diagnostics of those specifically. So, and the other thing I always wonder about, maybe Dr. Moore can explain this to me, how increased mortality, if we want to identify the cause of that, we tell somebody to go out and kill some pigs and see what's wrong with them. And it's like, really? Do we not ever stop and have the time to actually necropsy these deads as we go? Because the actinobacillus suis is doing something, that the chronic pericarditis is not, right? And if you go out and sample pigs that aren't doing well, chronic pericarditis. If you go out and sample the pigs that actually died, it's A. suis. And to me, there's a big difference there, right? In what the outcome of that information, what you'll do with that information. Diagnosis, I'm a diagnostic lab, so I got to go here. Diagnostic process. Diagnosis is a process of collecting information, thinking about it, analyze, research. Diagnostic accuracy. In the back of my head, does this make sense? Does this make sense? Does this make sense? It's going through my head all the time, right? And then, ultimately you got to make a decision, right? Ultimately you got to make a decision, but is it after we've gone through this process? Deductive reasoning. A little bit to say about that in a bit, but, that's taking facts and then taking that down to a conclusion that meets the facts, just like Sherlock Holmes said. And awareness of the types of bias, confirmatory bias, or what's our motivation for making these diagnoses. So if you look at a diagnostic lab report, generally we got, it's a little bit of history, pigs have pneumonia, what were the gross lesions? We did some diagnostic testing, we got these results, and we do a little histopath. What's histopath? These bugs aren't carrying signs that say who they are. Basically, they're creating lesions, and we go, this lesion is compatible or not compatible with what we're finding, right? If it's compatible, okay. If it's sort of compatible, but you should be thinking about this, maybe we can mitigate your diagnostic investigation. If it's not compatible, maybe we need to redirect, right? It's the value of histopath, as opposed to just finding a bug and running with it. And some of you, not you, the people that aren't here in this office, or in this audience, some of those definitely will run with just a simple laboratory test. So attending veterinarians make the diagnosis, not the laboratory. So if some of you are producers in here and your veterinarian say, well, the lab said this is what's killing your pigs, I'm sorry, we don't do that. It's the attending veterinarian that does that. Okay? So systematic iterative process, that's where that arrow comes back around. It's because, well, is it the same thing we had last time or not? Is it changing? That's how we kind of keep track of what's going on. Maybe we can identify other issues. And then this execution, how we do this is going to be dependent a little bit on what your question is. You know, what's killing this pig versus what's affecting this group today? What's having the greatest impact? We're going to have a different diagnostic modality, I think, for each of the diagnostic questions that are listed here. So it's, to me, part of the fun of being a diagnostician, not a scientist, is I get to pretend I'm one sometimes. You know, you get to develop a protocol. How do you approach finding a solution to this particular issue? Well, one way to do that, this is call it a customized submission form. And it's really busy, okay. But I get on the phone and I talk to a veterinarian that you know, we want to look through our system and answer this question. Why do we have so many pigs that are falling back? Okay, well, let's design a protocol to do that and do it in a systematic way. Let's have the veterinarian actually go out there and look at the pigs, score them clinically. Let's count how many are affected with condition A, condition B, how bad it is. Collect that information in a systematic way, and then, you know, actually submit some tissues and or specimens so that we can evaluate what's the ecology and epidemiology of the agents that are being active right there. And I tell you, as a diagnostician, you know, hitting the button and sending a report isn't near as much fun as talking to somebody, you know, and being engaged in the process. And I think going forward, we're going to have more and more need, I hope there is, more and more need for kind of personal interaction and personal engagement to help solve these bigger problems rather than finding the same thing over and over. You can go on and do a data capture. We're going to actually necropsy some pigs that we selected. Maybe some are acutely affected. A couple of chronics never hurt to see how they're going to end up. You can design this any way you want to, but it needs to be consistent in the information gathering part. Submit it with a protocol. This is what we're going to test for. It takes all the questions out of what we're going to do, but leave a lot of discretion for what you find on the farm, what else you'd like to do, what we find in the lab, what else we might want to pursue, right? So a customized submission form for a project or case series would be one practice tip that I would offer that a diagnostic lab should be willing to help you develop. Okay, Mycoplasma pneumonia is an organism that hits and stays. I'm a simple guy, right? It's not like a virus that hits and leaves, cleared by immune clearance real quick. Is it predictable? No. You know, it's going to locate on the cilia, it's going to hang out there, it may or may not cause clinical signs for a while, it may or may not develop full pneumonia or not. You know, it's probably going to cause seroconversion, don't know exactly when, in an individual pig, you know, and lesions probably going to develop, as you can see, mild, severe, chronic on the growth slides. You can see up there in the upper right with an immunohistochemistry, all that brown is colonizing mycoplasma early in the disease process. By the time it gets down here to fairly acute in this histologic picture in the center, a lot of peribronchial cuffing, a little bit of fluid in the alveoli, very hard to find the bug with IHC. So do you have to have IHC to call it mycoplasma? Well, not necessarily, but it would help with the confidence of that. Part of mycoplasma diagnosis would I think, go to sampling, you know, and so if our question is diagnosis of disease, not if it's there, but if we're trying to find disease, we're going to probably have to sample some pigs versus using serology or some other epidemiologic tool just to ask the question, is it there or when it's there? Often the sampling seems to be delegated, and I understand why. We're all busy and can't get there, and these farms are far away. But in my mind, you mess up sampling, and nobody can fix you. Nobody can bail you out. Lab can't bail you out. Can't, right? You've already messed it up. So should it be delegated? And is it an SOP-driven thing? How hard can it be? Ooh, one of my least favorite statements. The devil's always in the details, right? So who to sample, what to sample, how to sample, you know, we got that pretty well figured out. It's a matter of execution. Who's going to do it? My commentary on culture generally. SOP-driven culture. Are we trained to do a task? Oh, yeah, that's good. Are we educating our workers, ourselves, or our children? Not sure about that. There's a difference between being trained and educated, right? Educated, I sort of understand the what, where, why, when, how. I sort of do. Not totally, but at least I have enough in here that I can think from, start to make some sort of assessment of outcome. So, diagnosis of mycoplasma hyonemonia. NPRDC. This isn't just for mycoplasma. They make these little swabs called Coban swabs. They look like little brushes, the fuller brushes of swabs, right? Wouldn't it be cool if you could just clip the trachea, take 2 swabs, put them down in there, whoosh them around a little bit on a pig that has pneumonia, and pull them back out, put them in the little container, maybe label them. That's always a good thing, to label your stuff, okay, right? And then clip off a few $50 pieces of lung. Which pieces do you really need? Gosh, you know, to me, it's really simple just to say a piece of everything that looks different. A piece of everything that looks or feels different, right? Do I need 10 pieces from some lungs? Yeah. Do I need 1 from others? Yeah, right? That's the educated part, right? Okay, so what's a submission actually look like then? You got 2 stinking swabs and some formalinized tissue you're going to send to the lab, and it's going to be, with that we can do PRRS, mycoplasma, flu, circovirus, in any bacterial culture, and the results will be just as good as sending fresh lung tissue. I guarantee it. We've known this for years, we just don't tell anybody. Okay, but I'm telling you now, something to think about, okay? By the way, those brush swabs, just on a recent mycoplasma challenge trial, using the brush swab technique into the airway versus the researcher actually taking lobes of lung that were affected, had 2 to 8 CTs improvement in detection. So that's, what, 10 to 100, 10 to nearly several, well, not 1,000, 10 to 100, let's say, times more sensitive just using a stinking swab than whacking off a chunk of lung. You actually could maybe train somebody to do that, right? Anyway, so finding mycoplasma, clinical signs, subjective tests. Gross lesions, subjective. We're not really confirming it yet. Histology, subjective. Well, crap. How do we know for certainty? Well, I don't know. How do you know anything with certainty? PCR is an objective test. So now we put all the information together and sort of play the odds. But at least our odds are better when we do the process in a proper sort of way. From 1 pig submitted or 3 pigs submitted, do we still understand what the impact is on the herd? No, I'm not trying to say that we do. This is what we found in the pigs you selected. You all out here know that mycoplasma vaccines are pretty darn good most of the time, as long as they're not confounded with other infections. Problems that we see generally are just in naive animals that ultimately are exposed. So vaccine alone is not sufficient to prevent disease in naive pigs. We see that time and time again. As far as mycoplasma diversity and what does it mean, hell, I don't know. Until somebody tells me with some sort of certainty, some sort of confidence, I'm not going to worry about the variation that we can detect with molecular tools. We have no evidence to support vaccine escape with mycoplasma, in my opinion. Welcome to the masquerade ball, the many faces of circovirus. Dr. Bailey Aruda is a young diagnostician in our laboratory, and she goes, after, 5 years of intense training in pathology, why didn't they tell us that circovirus could do so many stupid things? Right? You know, we learn it this way. Working in the D lab, we get to see it in every way it occurs, you know. And I think we got to, you know, have some sort of recognition that variation, diversity is the nature of biology. And so we're looking at all these different things, from reproductive thing to wasting to major edema problems to PDNS, all kinds of ways this disease manifests itself. And the thing about the goofy bug, I always looked at quite a few of these, and I just say, you know, that virus is going to go where inflammation is. So sending in 4 lymph nodes, those may not be where the inflammation is, and the IHC is going to be negative, but you send in a piece of colon or ileum, and it might be loaded, right? A lesion and loaded. And so you got to kind of be thinking about what tissue is being affected. Again, not SOP driven. This is more clinical, lesion. What should I be collecting? Anything that looks suspicious is something to collect for a circovirus diagnosis. I just put this up there because I'm colorblind. I'm a one-eyed colorblind pathologist. And everything I see is sort of shades of gray. But I can detect some color here. But the spectrum, right? The spectrum here of, virulence factors, dose, host factors, all these operate on a sliding scale that ultimately determine whether it's going to be just colonization or infection versus severe disease and PMWS. And fortunately, Dr. Hurley's here, and he's going to explain exactly why that happens, because I can't. It's called biology. So, criteria for PMWS is clear. We need clinical signs, lesions, and IHC positive. Okay, we all got that hammered into our brains. Well, can't they get sick and not die? Yeah, I think so. And so sublethal infections do happen. Very little IHC staining. It's a very subjective test. How do I know what role circovirus is having? Pigs can be infected. They can spike a viremia, have some lesions created, and then ultimately clear it. And then you catch the pig over here, and PCRs are barely detectable, and IHC is negative. Does it have a compatible lesion? Well, they're not pathognomonic, so it gets really hard to sort this stuff out. I'll give you that. And I will give you an example of that. This is a little bit cumbersome, but this shows the diagnostic lab, or my dirty underwear, because what we have here is this left-hand column is a PCR CT, right? And it goes from 7 down to 35 or negative, right? And so on cases where we did both PCR and IHC, which is the next two columns, how many were positive or negative by IHC? And so you first start coming down that column to 9, and you go, 20 of them were positive with IHC, but we had 1 negative. You go, that would be a false negative, wouldn't it, if we rely on IHC alone? And that's a whole bunch of virus in this pig that was detected by PCR. Okay? And coming on, the yellow highlights are discordant results or discrepancies. And until you get to a CT of about 20, you sort of expect that IHC is going to be positive somewhere. But then that starts to fall off as the CTs go up. Another area of concern is you get down to the negative PCRs, clear at the bottom here. 539 were found negative by IHC that were also tested by circovirus, or by PCR. However, 26 of them were called positive by IHC, and how the hell does that happen? It would be called laboratory error, judgment, tissue mix-up, whatever, right? Why am I showing you that? Well, it's skepticism, right? Do things make sense? And if they don't make sense, you got to be a skeptic, including stuff that comes from on high, from the higher echelons of Iowa State University or any other diagnostic lab. Has to make sense. PCVAD, no seasonality. People want to know, what are you finding? Well, about the same rate over time. Through the years, we're down around 1 or 2% of our cases. We can record a circovirus associated disease with it. And that would be the blue column there. Obviously we had 15% there in 2006 and 2007. That was pretty nasty. We don't want to go there again. Do we see a clear uptick in the number of cases or percentage of cases that are positive with circovirus right now? Over the last year or two, we have not. Doesn't mean it isn't a concern. It's certainly a concern if it's bothering your pigs. So, next question is, well, what are you seeing in terms of types and subtypes? As you know, PCV2A emerged in Canada in the 1990s. PMWS was described. Some called it circus virus. Can't fulfill Koch's postulates, therefore it can't be a real disease. You guys are really blowing it, right? It's one of those diseases you really couldn't appreciate until you had it. Once you had it, you go, this is real. So anyway, PCV2A was dominant, and then 2B comes on the scene, 2004, 5, 6, and is a predominant strain. And it turns out that mutant PCV2 or PCV2D described somewhere in 2011 or 12, and now appears to be becoming the predominant strain. 2C actually was a one and done type of situation, and there's also other circoviruses that are being talked about. I just want to say, with my simple mind sequence data on these kind of things demonstrates biological diversity, and it's really useful for relatedness and evolutionary biology. Where does this virus fit on the evolution? Where did it come from? Those types of things. It doesn't accurately predict virulence. It doesn't accurately predict cross-protection or immunity. That said, with these circovirus issues that we might be seeing, should we just sequence it? Probably. If we suspect virus escape, we definitely should. A few questions about concepts of immunity. One size does not fit all. How do we measure immunity? I think we're going to have some discussions on immune stimulation here. I really think these endemic diseases that are so situation dependent almost need to be characterized with field trials. I don't think there's anything we can do in a laboratory that can translate completely to a farm, right? And so one of my messages here is really get good at field trials. There's other factors to consider too. The idea of partial dosing a killed vaccine. I'm not sure that makes any sense to me because antigenic mass is really important. The idea of boostering. When's the proper time to booster? When it's convenient? Or should there be maybe 3 weeks in between, just to optimize that immune response, anamnestic response? Repeated MLV doses. Eventually, if you got enough immunity, I don't think that virus gets much beyond the end of the needle before it's sopped up. So what's that dose really doing for you? So how many doses do they need? Those are questions I don't know the answer to. Vaccine efficacy, another would be perception. What's our expectation of vaccine? With atrophic rhinitis, we don't want to see a crooked snout. If we see a crooked snout, the vaccine's no good. You guys aren't old enough to know that, right? I am. You miss one once in a while. We knew that. PRRS, it wasn't as bad as last time, so vaccine's helping, right? Isn't it all about expectations? I think it is, probably. We need some clear guidance on how to do that, how to evaluate those. So anyway, this list, you veterinarians in the audience know better than I, what factors can compromise vaccine efficacy, timing, using off-label, administration, are we really getting it into them? Did we handle it right? Blah, 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 on down the line. That's a checklist. I'm sure many of you have it as a checklist. And I would also say occasionally we have inaccurate conclusions from the data available, which includes diagnostic lab data. We sent in a pig, and we drew a conclusion from one pig, or 3 pigs, or whatever. PCV2A, 2B, 2D, relative frequency. If you take out all the research cases and the biopharma cases from Iowa State, it's still pretty clear that the mutant / PCV2D is increasing in prevalence. It's taken over as the predominant strain. I'm not sure we're seeing epidemics of PCVAD, but know that it is. And so then you kind of go, well, is there less protection? Is there a problem with cross-protection? Part of it's the denominator, right? Every case we're looking at, we're finding the mutant. It must not be protecting. Well, do you have PCV2D in the ones that you're not looking at then? Or 2B? What's the denominator that we're looking at? Maybe the rate of immunization failure really hasn't changed. Maybe there is a difference in magnitude, duration of viremia or virulence. There's all kinds of reasons that a change in a bug might translate to a change in vaccine efficacy, but simply a change in the genetic sequence isn't one of those reasons. I need more evidence than that. So my take home right now, I think current vaccines look like they're cross-protective. Vigilance is warranted. I think we've got to continue to watch this really close. I think the pigs will tell us, probably faster than the molecular geneticists will tell us whether there's a true vaccine escape or not. Okay. What is the protection? How is it measured? These are some questions that, that your biopharma company's asking. How much data should we provide to you, the producer, you, the veterinarian, before you'll, quote, believe us or think about using our product, or how does our product fit into your system? And I think every disease is going to be different. Every vaccine is going to be different. And that's why you're here to this meeting, is trying to get the background information to objectively evaluate, what's the best measure of protection? How much data is enough? And again, back to that field trial thing. Do we need to be doing customer-specific field trials? I would say, yeah, probably. One bunny trail, one more bunny trail. Those that know me know I'm an agnostic on a lot of different things, not necessarily religion, but on science here. Classic statistical analysis, to me, is wonderful to have a well-designed trial that gives us insight, information into the biology and context of how agents interact with each other. But I rarely am able to take those studies and chisel them in stone and say it's true all the time. External validity is going to vary, right? It's going to vary a lot. And so, to me, classical statistical analysis, p-values, Gaussian's type of distributions are all something to think from, not necessarily chisel in stone as absolute fact. And I would challenge, and I think most systems have taken a look, it's harder to do probably, but challenge us to be thinking about statistical process control. Biology is more random than we want to believe, and so following our interventions with SPC charting is good. Bayes, there's a guy by the name of Bayes in statistics that sort of figured that, as time changes, conditions changes, the probabilities change, and so we need a system to do that. Not point-in-time statistics, but statistics over time. And so we got to let the process inform us. Feel free to change our mind. Tools, a diagnostic section, we're going to be talking a little bit about root cause analysis in our diagnostic session, but it comes from the manufacturing world of, Ishikawa diagrams or whatever, but trying to be able to think through all the contributors and their relative impact to disease expression. There's a lot of things that would contribute to disease expression. Infectious agents are what get expressed. Do we need to go there first, or should we go there last? Did the curtains malfunction, or do I want to blame the Haemophilus parasuis? If I'm making system decisions, I would like to evaluate those other things too as risk factors. Average does not acknowledge tails of distribution. If you want to know what's killing the pigs, what's causing ill thrift in pigs, what's causing variation, sample the bottom of the distribution. Don't get caught up in doing epidemiology studies when the question is what's killing the pigs, what's making the pigs sick. Those are diagnostic disease questions. Epidemiology would be more following that infection through the population over time, not necessarily paying attention to what the impact is. Busy slide, but we got our diagnostic process there on the left. And with that information, we kind of go over to the brain there. We got our facts, and we're going to deduce from the facts a theory or a conclusion, just like Sherlock Holmes, right? I can tell when somebody hasn't done much deep thinking because I get this phone call that says, Schwartz, I got this result. I did this test, got this result. What's it mean? And I'm going, you're an inductive thinker, right? You're like Watson. I'm going to take one piece of information, I'm going to think of all the possibilities, right? And then I'm going to pick the one that I think it is, right? You see the difference between inductive and deductive. I mean, I don't mean to insult your intelligence, but I see it, I suffer from it all the time. So, any rate, ideals and obstacles going forward. True scientific merit. I think we're in an age where we're going to struggle with ability to truly evaluate valid information because we have the internet that will find something else virtually every time. Ultimately, I think, the field trial thing, what are blinded, randomized, controlled trials? And if you're going to do a field trial, why would you not want to do it right? Right? Why would you not want to do it right? What part of that's not important? Oh, well, anyway, we won't go there. There's going to be a lot of regulatory economic oversight coming down the pike. It's going to have some impact on what we do, how we do it, how nimble our businesses can be, whether you're a biopharma business or whether you're a swine producer. I think having to deal with the economic constraints that might stifle innovation, litigation avoidance in my world. Research gets done very expensive and very slowly because universities concerned about litigation and image. Bureaucracies don't help that much. So science does lead to novel biological interventions, and I think you're going to hear this afternoon, we're always looking for the technology that's out there that can help us do our jobs better, help us provide better health and welfare for our pigs. I think we'll skip the vaccinology part, and ultimately, I think what we want to get to as kind of a closing here would be, in my mind, time changes thing, evolution happens. A lot of times we help it along with our unintended consequences of our decisions. I think a lot of what we're doing needs to be looked at in a longer term rather than the short term, next quarter, next year, in terms of being able to keep our industry viable going forward. Certainly there'll be new organisms reemerge. We need to be vigilant and wary about that. What are the motivations to be able to react or change to those? Certainly economics are a problem, competition, drive for bigger, better, more, ego, if you will, fear of reality of the externalities, regulation, disease, consumerism, antimicrobial resistance. There's always something that's going to be forcing us to do something we didn't plan on doing. It might be something we should do, maybe something we have to do. And I'd leave you with more infectious disease pressures that are coming. We don't have less, we have more now. Our system has created more disease pressure. I don't know if you agree with me, Max, but I don't think we had quite the frustration in 1978 that we do now. It's a systematic thing, right? What can we do to our systems? We need to be thinking about not what we can do to the pig, but what are we doing to the system? So what should we start doing? What should we stop doing? And who's next? The theme of the ASB is, of course, standing on the shoulder of giants. It's a letter from Isaac Newton to Robert Hooke. If I have seen further, it's because I stood on the shoulder of giants. I really do value all the insight and relationships that I've gotten over the years. And need to take some time to enjoy life while you're doing it. Thank you.